Good evening, everyone, and welcome to our final journal club with authors for 2024. I'm sure you agree no disease makes one think maxillofacial like ameloblastoma, and we are closing the season with targeted therapies in ameloblastomas and ameloblastic carcinoma. I'm Mandana Donahue, founder and director of Oral Pathology 360, and your technical host for this session. For those who are joining us for the first time, a warm welcome. Oral Pathology 360 is an international non-profit with a mission to elevate the knowledge and skills of oral and maxillofacial diagnosticians through accessible online education. And all you need to do to stay connected and informed about our content is hit subscribe and turn on notifications. But a couple of quick announcements before we begin. The first is now you can get certificates for attending the live stream. This is a special benefit for our channel members. All you have to do is actively engage in the session. That means contributing to the discussion in the live chat and filling out a form at the end. The link for that has already been shared via community post for members. If you're not a member as yet, don't worry. All you got to do is just hit the join button, which is seen below this video, and get started. The second announcement is about, sorry, right, is about the open mic contest for the faculty, which is now open for submissions. If you are a healthcare professional, that means not a student, but a healthcare professional, passionate about oral and maxillofacial diseases, this is your chance to shine. You will find the link pinned at the top of the chat. Now let's dive in. Please join me in welcoming our session host and moderator, Dr. Pouyan Aminishakib, who will introduce our esteemed guests and guide us through today's discussion. Dr. Aminishakib, the floor is yours.
Thank you, Dr. Mandana, for your nice presentation and introduction. Hello, everyone. Thank you for joining the 8th online interactive journal club in association with Oral Pathology 360. And I would like to express my sincere appreciation to Oral 360 and the founder of this organization, Dr. Mandana, for supporting us in 2024. And I hope to continue this program in 2025. Okay, let's immediately go to the session. It's a great pleasure for me to host three eminent researcher from Uruguay. First, Dr. Ronell Bologna-Molina, and also Dr. Felipe Martins Silveira, and also Dr. Lauren Frenzel. They are all from Department of Diagnosis in Pathology and Oral Medicine, University de la República Montevideo. And we are talking about a very interesting topic, an article focused on targeted therapies in ameloblastomas and ameloblastic carcinoma. Dr. Ronald, thank you for accepting my invitation.
Th- Thank you, Dr. Pouyan. Thank you, Dr. Mandana, for this invitation. It's a great honor for us can be here today. Thank you.
Welcome. And Dr. Philip, thank you for accepting my invitation.
Thank you very much for the opportunity to be debating, discussing such an important, interesting point with you. Thank you.
Welcome. And Dr. Lauren, thank you for accepting my invitation.
Thank you, Dr. Pouyan and Dr. Mandana, for this invitation for our group. And it's a privilege to us to share our insights with a knowledgeable group. So thank you so much.
Great. And Dr. Mandana, we are ready to quickly to go to the first video on this topic.
Hello, everyone. First and foremost, I would like to thank the Oral Pathology 360 program for the opportunity to participate in this activity. I also extend my gratitude to Dr. Pouyan and Dr. Mandana for the conception and management of this wonderful project. My name is Frenzel Schuch. I am a dentist with master and PhD in neuropathology and neuromedicine, and currently I am a professor in the Department of Diagnosis in Pathology and Neuromedicine at the School of Dentistry in the Universidad de la República Uruguay. And today we will discuss the topic of targeted therapy in ameloblastoma and ameloblastic carcinoma, which is based on a recently published systematic review conducted by our group that includes contributions from experts in the field of odontogenic tumors. This presentation is divided into two parts. First, I will introduce the target therapy in odontogenic tumors and present the study objectives and methodology. And in the second part, I will present the results, conclusions, and implications of our findings. So, odontogenic tumors comprise a category of diverse lesions with various histological features and clinical presentation. In general, these tumors represent 1 to 9% of diagnoses among oral and maxillofacial lesions. These lesions can grow to significant size, often affecting vital nerve structures, making their management challenging. As the gold standard treatment of some of these odontogenic tumors is surgical resection, it may result in significant morbidity, affecting the quality of life of the patient. In this respect, new modalities of therapy are necessary. One of the recent studies underlined that contemporary treatment regimens and follow-up methods focus on more than just ensuring survival. They also aim to enhance the quality of the survivals of this patient. So, in this line, the targeted therapy represents a treatment with drugs which interact with or block synthesis of specific cellular component characteristics of the individual disease in order to stop or interrupt the specific biochemical dysfunction involved in progressions of the disease. The literature have been to demonstrate the exciting potential for target therapy in the management of odontogenic tumors, particularly in terms of their possible neoadjuvant applications. Firstly, target therapy show considerable promise as a pre-surgical or neoadjuvant approach for management these tumors. The idea here is that target therapy could be used to reduce the tumor burden before surgery, making this surgery procedure less expensive and potentially improving patient outcomes. In terms of evidence, preclinical studies have shown that targeted therapies may serve as a novel, minimally invasive adjuvant treatment, especially for ameloblastomas. These studies suggest that target therapy could be a viable way to target the tumor cells directly, offering less invasive options that could complement surgical resections. So, in this regard, the aim of our study was to summarize the current evidence on the different forms of targeted therapy, effectiveness, and drawback of this course of treatment for odontogenic tumors. In conducting this systematic review, we adhere to the 2020 PRISMA guidelines, and our review protocol was registered in the Prof. Our review was framed around a PICUS question. Specifically, we examined individuals diagnosed with odontogenic tumors who had received target therapy, comparing their outcomes to cases treated with other therapy or where no direct comparator was available. Our primary outcome of interest was to respond was the response to targeted therapy. Review articles, conference abstract, as well as in vitro and animal studies were excluded to, for this review to maintain a clear focus on clinical evidence. In August 2023, we conduct electronic search across four databases, complemented by a search of great literature. The searches were unrestricted in terms of publication date or geographic region, allowing us to capture the widest possible range of relevant studies. Our exhaustive search strategy incorporates both mesh terms and free text terms. For study selection, we used EndNote software to manage reference, where duplicates were removed upon identification. Once the duplications were eliminated, one author reviewed the titles and abstract of all remaining studies, selecting those that meet our eligibility criterion. For any doubt, a second author provided a resolution. From each eligible article, specific data items were carefully extracted, and these findings, the data were analyzed descriptively. To appraise the methodological quality of the included studies, we applied tools from the Joanna Briggs Institute at the University of Adelaide for case report or case reviews. So, this concludes the first part of our article. Before we proceed to the second part, we are open to any comments, criticism, or questions you may have. And please feel free to share your thoughts or ask for any clarification.
With the targeted therapies. And then, of course, we will see the results of the study in some minutes, but it is an important point when we are talking about methodology of a systematic review.
Okay. Okay, great. Thank you. Also, I would like to invite all audience to share their questions with us in the chat box. And I would like to share one of the questions with you, Dr. Lauren. Did you have any children in this study? Because one of the audience asked about that is this targeted therapy can be used for the ameloblastoma in pediatric patients?
Yes, excellent question. Thank you for the question. We have some limitations and careful when about pediatric patients when we need to use a multidisciplinary group because some metabolic and some specific compound of these pediatric patients is different for the adult patients. So we need to take care and avoid of this therapy with this specific group.
Pediatric patients, special pediatric patients, special care must be taken to preserve as much function as possible. So given the potential for jobs growth and development. So there are some limitations in pediatric patients. For example, pediatric patients may respond differently to target therapies due to the difference in the drug metabolism. side effect profiles and development considerations. So we need to take care when we use target therapies to pediatric patients.
Okay, great. And Dr. Ronald, do you remember? I forgot that how many children did you include in your study? I think um, you have a few cases.
I cannot remember the number exactly. Lauren, do you remember
Okay,
the number of cases?
I think that I included 5 cases of
Okay.
individuals,
great.
yes, up to 18 years.
Exactly. And you well mentioned, Dr. Um, uh, Ronald, that the importance and the crucial note about the inclusion criteria is about the make a balance between the impact of the surgical excision and compare it with the targeted therapy. My question is about that. Is there any possibility for the side effect if the patients receive targeted therapy? It means that patients may suffer from some side effects which commonly seen in conventional chemotherapy.
Yeah, I think that the side effects for target therapy are mild. So the most of the adverse effects were rash, arthralgia, and head, headache, and asthenia, and nausea. So I think that the side effect doesn't have the problem for this therapy.
Yeah.
Compare. You mean
Yes.
comparing with the surgical excision? After a surgical wide excision, most
Yes.
patients lose their normal function and their cosmetic, features, and it is necessary to find a replacement for the surgical excision. And you well explain in your article this targeted therapy. Dr. Philip, do you have any comment about it? The importance of targeted therapy you well mentioned in your paper.
Yeah, I would like to comment about the potential use of this therapy in pediatric patients.
Mhm.
And I think that, of course, we have little studies to conclude about, for example, adverse events in this population. But I think that the potential of this therapy in this specific type of population, the pediatric patients, is related to reduce the morbidity that this type of lesions can affect these patients that are in a phase of growth of the craniofacial skeleton. So I think that it is a potential therapy to be used as a neoadjuvant therapy with the gold standard therapy that is the surgical removal of the lesion. But of course, we need more studies to conclude something. And it is important also to mention that it's not approved by FDA, this type of therapy in the population with odontogenic tumor. So we have uh, wait and to have more studies to conclude something.
Okay, great. Let me ask you, Dr. Philip, again a question. Before getting started, the panel we talk about other odontogenic tumors. Do you think that I saw that you include ameloblastoma and ameloblastic carcinoma, collect these cases in your study? Do you recommend to consider other odontogenic tumors, for example, calcifying epithelial odontogenic tumor or other odontogenic tumors to be treated using targeted therapy?
Yeah, yeah. I think that Based in the study that we are discussing and in the studies that are available nowadays, currently we have this therapy more related to ameloblastomas and ameloblastic carcinoma due to aggressive type of these odontogenic lesions. So I think that thinking in other types of odontogenic tumors, I guess that the most important thing is to think about the aggressive behavior of the odontogenic tumor itself. Of course, thinking in other types, we have to consider the genetic mutational profile of the tumor to know what targeted therapy could be used for the other specific types of lesions. And then, of course, the feasibility of the use of this therapy, considering again the aggressivity of the specific lesion studied. But yes, it is important to consider all other types of odontogenic tumors.
Uh, Great. And I would like to invite all audience and researcher around the world to be in touch with the authors of this article, especially Dr. Ronald, the first author of the paper, to collect more cases and to share more details of their cases with the authors. And let me ask the last question in this section from Dr. Lauren. One of the audience, Carol, asked you about the databases you have used to select articles in your paper. Do you have any explanation for the participant?
Of course, thank you for the question. So, as Felipe commented, initially we used a full strategy for all odontogenic tumors, but we founded only ameloblastoma and carcinoma ameloblastoma. So, regarding the databases, electronic search were used without restriction of a region or of any time of publication. And you use it for mainly databases, Scopus, Web of Science, PubMed, and Embase. And additionally, we use the Gray Literature. So we access the Open Gray and the Google Scholar, and additionally a manual search of all the reference of the included studies. So our search process include all these databases and Gray Literature and manual search.
Okay, thank you. And we have one more question from Osmani. I would like to invite Dr. Osmani to wait for the next session, because after the second presentation by Dr. Lauren, we will have time to discuss the details of the drugs or targeted drugs in the next session. Okay, Dr. Mandana, the stage is yours for the second video.
Moving forward, I will now present the key findings of our systematic review. And in this slide, you can see the flowchart outlining the process of our search. A total of 492 articles were identified through the FAR database, manual search, and Gray Literature. And from these, 15 articles reporting 17 cases of odontogenic tumors treated with targeted therapy were included in this systematic review. Regarding the general characteristics of the articles, the studies were published between 2040 and 2022, originating from 6 different countries. Notable, the majority of case studies came from the United States. The majority of cases reported were ameloblastomas, including primary, recurrent, and metastatic ameloblastomas. Additionally, there were 2 reported cases of ameloblastic carcinoma. Of the reported data about ameloblastoma cases, most individuals were male, with a mean age was 38 years, and the ratio of mandible to maxilla was 5 cases to mandible for 1 case affected maxilla. Regarding the ameloblastic carcinoma, 1 case was identified in the mandible of a 14-year male, and the other case was in a 59 years old individual without information about sex and specifically anatomical location. In respect to the mutations and target therapy in ameloblastoma cases, 11 cases reported a BRAF mutations. And for these cases, a BRAF inhibitor was used with 4 different types or combinations of target therapy. Dabrafenib was used in 5 cases, vemurafenib in 2 cases, the combination of dabrafenib and tramatinib in 3 cases, and 1 case used tramatinib alone. Dabrafenib and vemurafenib both demonstrated partial response with a significant reduction in lesion size. In 1 case of metastatic ameloblastoma affecting the lung, the combination treatment of dabrafenib and tramitinib resulted in complete resolution of the lesion. However, when used alone, tramitinib failed to produce a response in a case of primary ameloblastoma. Another mutation identified was the FGFR2 in 2 cases of ameloblastoma. In 1 case, a 62 years male was treated with levantinib, resulting in a partial response, and the second case involved a 40-year-old male diagnosed with metastatic ameloblastoma. He was treated with erdafitinib, which led to a sustained response. 1 case of ameloblastoma with a PIK3CA mutation was identified. Notably, mutations involve BRAF and MED12 were also observed in these cases, and the patients were treated with copanlisib and achieved a partial response. In 1 patient, an NRAS mutation was observed, and the treatment with binimetinib led to a durable partial response. Now, regarding the ameloblastic carcinoma cases, a patient with a GTF-ALK mutation was treated with alectinib, resulting in the complete resolution of a mandibular lesion, and another patient had 3 distinct mutations: PIK3, HRAS, and FGFR2. These patients received a combination of tramatinib and levantinib, and after 8 months of therapy, he showed a favorable response. This diagram illustrates how targeted therapy are designed to interfere with specific molecular pathways that drive tumor growth. In particular, it highlights 2 main pathways, the MAPK-R and the PI3K AKT-mTOR. In the MAP-R pathway, therapies like dabrafenib and vemurafenib target the BRAF mutation, a key driver of tumor proliferation. Similarly, tramitinib and binimetinib inhibit MEK further down this pathway to reduce cell growth. On the other side, the PI3K AKT-mTOR pathway is essential for cancer cell survival. Here, drugs like copanlisib target PI3K, helping to block survival signals in tumor cells. Finally, alectinib targets Assoc mutations in specific tumors. Unfortunately, adverse events were reported in some cases, and we identified 11 cases referring some type of adverse effects. Among those, mild effects include skin-related as well as changes like thickened voice, abnormal hair texture, and dry eyes. Some systemic events were also noted by the authors, and 3 cases showed no observed side effects from the targeted therapy. So, with our review and reviewing all of the case report in the literature, we observed that genetic profiling plays a critical role in understanding the etiology of odontogenic tumors and guiding targeted drug therapies. Among the mutations identified, BRAF stands out as the most frequent mutation in ameloblastoma, present in approximately 70% of cases. Additionally, advanced techniques such as the second mass array have shown impressive potential for accurately identified BRAF mutations. Also, dabrafenib has been the most frequently used therapy, often administered in combination with trametinib, and has shown effectiveness, with one case achieving complete response. When used alone, however, trametinib has shown limited success, with one case resulting in a failed response. And for the other mutations, treatment targeting also led to partial response, demonstrating the potential of mutation-specific inhibitors in these cases. In our review, complete remission were observed in only one documented case. For the majority of the cases, targeted therapy were able to promote a persistent reductions in tumor size throughout the follow-up period. This effect highlights the primary advantage of the targeted therapy, especially in managing tumors at an advanced local stage where, for example, traditional treatment options may be limited. These findings underscore the potential role of targeted treatments in achieving durable response, even when full remission is not attained. Interestingly, the literature points some difference between pediatric and adult regarding targeted therapy. These variants often stem from several factors such as drug response, side effects, and tumor biology. We observe that when using targeted therapy in pediatric cases, it's vital to adjust dosage for children's varying size and metabolisms. While our findings offer valuable insights into the potential utility of targeted therapy in odontogenic tumors, some limitations need to be recognized, such as the sample size, the limited follow-up, and the limited information regarding, for example, adverse events of the targeted therapy. With this systematic review, we can take some home messages. Our results show that targeted therapy can reduce tumor growth and mild adverse events were observed. And this partial response could be beneficial in specific clinical scenarios involving advanced local stage tumors where a neoadjuvant reduction could impact the extent of surgery and cases of local recurrence when surgical options are limited. So finally, I would like to express my gratitude to our research group in neuromolecular pathology led by Professor Ronell Bologna-Molina. And I also want to extend my thanks to all the authors of this article, which has allowed us to gain valuable insights into odontogenic tumors and target therapy. And once again, thank you for the opportunity. We are available to discuss any feedback, questions, or suggestions. Thank you so much.
Thank you, Dr. Ronald, Dr. Lauren. Impressive presentation, and I do appreciate your great team in Uruguay. Let me ask a question from Dr. Ronald. We have two questions rather similar from our participants they ask about dabrafenib, one of the targeted therapeutic drugs that you recommended in your paper. Um, can we use this drug in ameloblastoma, all ameloblastoma cases, or we have to check the cases for a BRAF mutation, then this drug is indicated for the patient.
The K pathway for the target therapies are mitogen activated protein kinase MAP. So um, this pathway is crucial for cell proliferation, differentiation, and survival. And almost between 70 and 80% of ameloblastomas has a BRAF mutation.
Yes.
So dabrafenib is specific for BRAF mutation. So dabrafenib is indicated in all the cases that has the genetic mutation, and also can be used in another odontogenic tumors with BRAF mutation. For example, we can use dabrafenib in ameloblastic carcinoma, for example. And dabrafenib initially was used for melanoma. The classic use for dabrafenib was in melanoma. So, and melanoma has the BRAF mutation. So, in conclusion, dabrafenib is indicated in all that tumor that have has BRAF mutations.
Okay, great. And it seems that it can be used for the tumors that show the BRAF mutation, including most of ameloblastoma cases. Before getting started the program, we were talking about other odontogenic tumor bearing this mutation. For example, dentinogenic ghost cell odontogenic tumor and some other odontogenic tumors with BRAF mutation. Great. Dr. Philip, do you have any comments about dabrafenib or other targeted therapeutic drug?
Yeah, I would like to comment about dabrafenib, that was the most used in the study that we are discussing, and it is because obviously of the BRAF mutation that is evident in some cases of ameloblastomas. So I would only add that, of course, dabrafenib is indicated in cases that have a confirmed genetic profile of BRAF mutation, because in unmutated or wild type cases, it is not effective. And I would like to add that these cases would be indicated, the use of the targeted therapy, in cases of unresectable, recurrent, or metastatic tumors also, and with as a neoadjuvant therapy. And then the indication would be, in this case, of genetic profile and aggressive and unresectable or metastatic or recurrent cases. And of course, nowadays it is used off-label because we don't have the formal approbation for using ameloblastomas, as we have in melanomas, as said Dr. Ronan.
Okay, thank you for your well descriptive response. And let me ask Dr. Lauren a question about you had one case with complete response. Would you please explain? Oh, I think we don't have Dr. Lauren. Let me ask this question from Dr. Ronell. Dr. Ronell, I saw that you had a case with complete response to targeted therapy. It is great and it is very hopeful for the patient suffering from destructive and expansile ameloblastoma or ameloblastic carcinoma. What kind of targeted therapeutic approach were used for this case?
Um, Only one case has pathological has a totally complete response. And this case was one case. Um, uh, in this case was only for metastatic ameloblastoma. So the complete response was for metastatic ameloblastoma, and all the other cases um demonstrated only partial response. So I think that the main idea for target therapies are only reduce the size of the tumor, and after that we can perform a better surgical approach. But a complete response was only in one case, and this one case was a metastatic ameloblastoma.
Okay, very well. And Dr. Lauren, we didn't have you for a few seconds. And let me ask you one more question about the recurrence cases. How many cases did you have in your study with recurrence? And do you think that targeted therapy uh, has a significant impact on the recurrent cases of ameloblastoma or ameloblastic carcinoma? I think you are mute. Could you unmute? You are not audible.
There seems to be some other problem because
Oh,
Yes,
her mic
yes.
is not on mute. Yeah,
okay.
can you try?
Okay, no problem. Please let me share this question with Dr. Philip. Philip, do you have any comment about the recurrent cases? And do you think that targeted therapy has a significant impact on the recurrent cases of ameloblastoma or ameloblastic carcinoma, or there is no difference between recurrent case or primary cases of these tumors?
No, sure. I think that it was one of the important situations that we could consider the potential use of targeted therapies in cases of odontogenic tumors, specific ameloblastomas. Recurrent, as I have said, I have already said, recurrent cases metastatic cases when we consider metastatic ameloblastomas. Are cases that we could consider this personalized therapy adjuvant with the surgical approach. So, in some cases of difficult treatment, as the recurrent ones, the targeted therapy are mentioned as a potential adjuvant therapy, probably no as a complete resolution therapy, but repeating as a adjuvant therapy to surgical approach. So I think that in comparison of the primary cases of ameloblastoma, yeah, it is an important way to study.
Perfect. Thank you for your reply. And let's go to the questions from the audience. Anna asked you about the signaling pathways targeted in the ameloblastoma and ameloblastic carcinoma. I would like to invite Anna to review the article because we have a very well descriptive figure in the article that the authors well mention the two pathways in the cell that they can target using targeted drugs. Dr. Ronald, do you have any comment to add for Anna about the signaling pathways commonly targeted by drugs?
The the K pathway is a map ERK pathway, but P13K Akite emitter also can be a target for these therapies. But I think that the key target is map ERK target, and especially BRAF mutation.
Okay, great. And another question from Lauren. Can you? Are you with us? Can I cannot hear you? Can you? Okay, no problem. And let me ask the next question from Dr. Felipe. Niraj ask you about the correlation between histologic pattern and the mutation and the type of mutation. Did you review these cases regarding microscopic findings? Did you classify them according to the microscopic findings or histologic pattern of the cases, or you didn't consider the microscopic features of the cases?
Indeed, this for reviewing the study that we are discussing, the histological, the morphological patterns of the cases were not considered, and the studies does not consider this point. But I think that nowadays, what we know is that there is no a correlation between histological pattern and the kind of mutation. When we are talking about ameloblastoma specifically, I would say that we does not have this correlation. Sometimes we have a correlation of location of the tumor with BRAF mutation or even with SMO mutation, but with histological pattern, it does not have a correlation. But I think it would be an important point to study the maybe the comparison of morphological patterns in cases treated with targeted therapies before and after the therapy, and also to prove or to test the mutational profile of specific cases that were treated with targeted therapies. I think it's a very interesting point to think.
Okay, thank you very much. I think we have a few minutes to wrap up. Then let me ask the last question from Dr. Ronald. Do you have any plan for the future to collect more cases and continue this brilliant project, scientific project for the future? Do you have any plan?
Yes, we are planning to collect many cases of odontogenic tumors. We are planning to collect malignant odontogenic tumors. And after that, we are planning to perform a genetic profile of these malignant odontogenic tumors and, uh, and, um, and perform a review about all the genetic profile of these malignant odontogenic tumors for planning for future target therapies. So I think that the key benefit of neoadjuvant molecular target therapies is that they can significantly reduce the surgical morbidity seen in the radical surgery and with malignant ameloblastomas and recurrent ameloblastomas. So if we can perform a big study with some cases of malignant odontogenic tumors, maybe we can suggest this new approach for target therapies. One disadvantage for these target therapies is the cost, no? If are very expensive. For now, I think that the medium cost of these target therapies is 1,050 per month, dollars per month. So if you can reduce the size of these tumors, the cost is very expensive, no? Because the treatment it's almost for more than 1 year. So the cost of the treatment until these days is very expensive. But the first step is su- suggest this new treatment for 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 all the odontogenic tumors that has the BRAF mutation and also for the malignant odontogenic tumors.
Yes. Okay. So let's just move on. First, let me remind everybody, if you appreciate the presentations, please put a like so we know and the presenters know that you liked it, and also YouTube will show it to more people. And also share it and comment on it. Now, I will move on to your certificates. Yes. So thank you so much, Dr. Ronald. It was
Thank,
it's a very interesting paper, and it was really nice of you to share it here with us.
thank you, Dr. Mandana, and
Thank you.
thank you,
Thank
Pouyan.
you. Yes, we will tell Pouyan when he's back.
Yeah,
Okay.
Oh, he's back.
I
Oh,
think he's
sorry,
back.
Yeah,
sorry,
Pouyan. Yes. Okay, we
sorry.
moved on,
Thank you.
and we
Yes,
have
great.
reached the certificates. You can continue now.
Okay, sorry for this connection. A great discussion. I would like to express my sincere appreciation to you, Dr. Ronald, Dr. Philip, and Dr. Lauren. Great presentation. It's very impressive, and it was your generosity to share your knowledge with us. And I would like to invite again all the audience to get connected with you directly to expand this research. Uh, Dr. Ronell, thank you very much for being with us. This is your certificate of appreciation. Thank you very much.
thank you, Pouyan. Thank you.
And the next one, please. Dr. Philip, thank you very much for being with us. It was very kind of you. Please stay in touch with Oral Pathology 360 in future.
Sure. Thank you. Thank you for the opportunity. Thank you for this project. It is a very interesting project, and we are in touch. Thank you.
Thank you.
Uh, Thank you. And also, Dr. Lauren, it is very kind of you to provide this connection with professors, and we will be in touch with each other for the next project. and I hope to see you soon in near future. Thank you, Lauren.
Thank you, Dr. Pouyan, Dr. Mandana. It's a pleasure for us.
Now, let me also say thank you so much to all of you for being here, for sharing your knowledge, and this was a very interesting session. Thank you so much. And of course, Puyan, thank you too for hosting the session. Yes.
Welcome.
I hope all of you will be back soon on the channel.
Sure.
Right.
Okay.
Thank you
Have a
for
nice
everyone.
day.
Have a nice
Have
day.
a
Bye.
nice
Thank
day,
you.
Thank you.
everybody. Bye. Thank
Ciao.
you
Bye
so
bye.
much. Bye.
Bye.